Hello, everyone. Welcome to our delegates to this special Scapholunate Ligament Injury webinar. It's a combined webinar provided by the Journal of Hand Surgery European volume, the Journal of Wrist Surgery, and also supported by the Asia Pacific Wrist Association, and also co-supported by IWAS, the International Wrist Arthroscopy Society. I'm Matthew Brown. I'm a hand surgeon here in the UK in Edinburgh. We've got an incredible international panel from North America down to the Asia Pacific, and I'd like to introduce a few of them in turn. So we have Bo Liu, who's going to be my co-chair. He's a hand surgeon in Beijing, China, professor of orthopedic surgery and chairman of the APWA Education Committee. He also runs the Beijing arthroscopy course. We're lucky to have the editor-in-chief, Wei Lam, of the Journal of Hand Surgery European. He's a plastic and hand surgeon working in Singapore, previously working in Edinburgh. He's the editor-in-chief, as I said, of the European Journal, and he's president-elect of the BSSH, taking over in 2026. We will also be joined by Toshi Nakamura, who's in Tokyo, Japan. He's the editor-in-chief of the Journal of Wrist Surgery. He's a professor of orthopedic surgery and past president of both APWA and IWAS. And next, we have representatives from APWA, including Dr. Jeff Ecker, who's a past president of the Australian Hand Society and also president currently of APWA. He works in Perth, Australia. We will introduce our authors as we go through, and I'd just like to start a video introduction from Jeff.
On behalf of the Asia Pacific Wrist Association, I'd like to welcome you to the Combined Journal Club on Scapholunate Injury. The Asia Pacific Wrist Association was formed approximately 9 years ago by P.C. Ho, and essentially it was an enthusiastic group of surgeons, 41 surgeons over 21 countries, who were committed to the evolution and the understanding of the conditions of the wrist. It was also committed to teaching the wrist throughout the Asia Pacific axis. Bo Liu, the head of the Education Committee, has been working on establishing links and collaboration with other societies. And as a result of this and the support of Toshi Nakamura, Editor-in-Chief of the Journal of Wrist Surgery, and Wei Lam, the Editor-in-Chief of the Journal of Hand Surgery European, that this combined meeting has been formed. If you wanted to pick a topic to stimulate discussion and collaboration, scapholunate injury would certainly be one of those topics. It's a spectrum of injury, ranging from scapholunate, perilunate, triquetrolunate, floating lunate, plus or minus triangular fibrocartilage injuries, and there's acute and chronic aspects of it. So it's just not one condition, it's a heterogeneous basket and a spectrum that we're dealing with. And I know that when I see patients, and I suppose for a lot of you it's the same, when you see people with scapholunate injury, what you want to know is how do you make a clear diagnosis, how do you examine people, what images are appropriate, and the importance of clinical examination and arthroscopic examination to make that diagnosis. But the key is the outcome. What are these people going to be like 3, 6, and 12 months after? Are they going to be better for our intervention, or were they best left alone? It gives me great pleasure to invite our experts who will be on the panel with our moderators to stimulate the discussion after we've presented these papers. Mireille Esplugas is co-director of the Institute Kaplan and head of the education courses for IWAS. Greg Bain is the President-elect of the Australian Hand Surgery Society and past President of the Asia Pacific Wrist Association and IWAS. He is also on the board of the International Federation for Surgery of the Hand. Both these individuals are world experts in carpal injuries and carpal ligament injuries, and I look forward to the interesting discussions. I would encourage the audience. There are many experts in the audience with an extraordinarily large experience And if you have something to say, interject or raise your hand, and it'll be up to the moderators to coordinate the discussion. I look forward to hearing the discussions. Thank you.
Thank you.
Okay, thank you, Jeff. Thank you, Jeff. So we was so exciting that we have 4 papers that was selected by both chief editors. So the paper number 1 is from Dr. Robert van Kampen from the Netherlands. Paper number 2 will be presented from the Christophe Marcelin from France. And paper number 3 was presented by Scott Wolf from the United States. And paper number 4 is presented by Mark Ross from Australia. So we're eager to see what happens next. So Matt, please.
Thank you, Bo. So paper 1 from the Journal of Hand Surgery European. The title of the paper is Midterm Outcomes of 3 Commonly Used Surgical Reconstructions for Scapholunate Instability, published last December. I'll hand over to Robert van Kampen to present.
Good day, everyone, or maybe even good night, depends on where you're tuning in from. My name is Robert van Kampen, as Matt just said, and I am a plastic and hand surgeon from the Netherlands, and I have the honor and pleasure to present you the results of our paper that was published thanks to Journal of Hand Surgery in December 2023. And it's about the 3 most common or commonly used surgical reconstructions for SL instability. It's one of the most common ligament injuries of the wrist and can lead to a slack wrist arthritis, but the natural course is unpredictable. And also that's why many different surgical interventions have been proposed. But still there is no ideal treatment with consistent outcomes. So the aim was to compare 3 techniques at a single institution. A retrospective cohort review was conducted at Mayo Clinic, Rochester, Minnesota in the US. Any form of capsulodesis, the classic Brunelli or the modified, and the capital Hammett bone ligament bone graft between 1990 and 2012. More than 2 years follow-up, and adults from 18 to up to 85 years old. And here are some exclusion criteria. Let me describe briefly the 3 techniques. Capsulodesis, many forms have been introduced. In the right lower corner, you can see the Blatt capsulodesis. It's an illustration from an article from one of the other presenters. And you can see a dorsal flap from the radius connected to the distal scaphoid. And this could result in too much loss of wrist flexion. And that's also why different other techniques have been introduced. Here you see Vigus from ulnar-based distal intercarpal ligament strip connected to the scaphoid. And here with Richard Berger at Mayo Clinic, a radial-based strip of distal intercarpal ligament connected to the lunate. Then bone ligament bone. In literature also several donor sites have been proposed from the foot, the hip, the extensor retinaculum. Some have donor site morbidity. Professor Ritt, also from the Netherlands, did research at Mayo Clinic, and he used the capital Hammett autograft, and he studied load to failure as well, with no significant differences, and has close properties to the native dorsal SL ligament, and with minimal dorsal donor site morbidity. Still the volar ligament is intact. Then the Brunelli tenodesis. Here's some illustrations from the original article in 1995. They stated that the STT ligaments are the primary stabilizers, and they can be found in the deep part of the FCR sheet. And that's why a strip of the FCR tendon was used and tunneled, as you can see here, through the distal part of the scaphoid and then secured to the distal radius. This again could result in loss of wrist flexion. And that's why modifications have been introduced. Van den Aad-Bele and Garcia Elias, they secured it with a suture anchor to the lunate and through a slit in the radial triquetral ligament, and then sutured back onto itself. The results in our paper, 60 patients, 64 wrists, returned to questionnaires, and of these, 46 wrists were returned for examination and radiographs. Here you see one of the tables. I'm not going to go into too much detail, but there was almost 12 years follow-up for capsulodesis, 6 for tenodesis, and 9 for bone ligament bone. There were no statistically significant differences in the groups, and there was only significantly longer follow-up for capsulodesis compared to the tenodesis group. But in the questionnaires, there were no significant differences. Here, for the objective outcomes group, slightly shorter follow-up, significant improvement for the modified Mayo risk score, and the bone gap for bone ligament bone group was significantly smaller. But in pre and post-operative range of motion and grip strength, there was no significant difference. Then a slide about post-operative pain. Most patients, 13 or 14 in capsulodesis, 12 or 14 of tenodesis, and 10 to 13 in bone ligament bone, had none to mild pain at rest, but it could go up with activities for some patients. And in all these groups, there were some patients with radiographic deterioration, but it didn't always correlate with poor functional outcome. So to conclude, it's a relatively long follow-up. The numbers are low and a low level of evidence, but no technique seems to be clearly superior to another. And that's why also with patients without severe pain or disability should also be taken in consideration to refrain from any intervention. And also surgeons, they should use a technique that produces the fewest complications in their hands. Thank you.
Thanks, Robert. Excellent summary of your paper. I will ask Maria. Maria, what do you make of the paper, and any comments or questions for Robert?
Thanks, Robert. This is a good paper. Thank you very much for your effort for publishing it. When we go deep on it, we see that the angles improve with time, and I don't understand how this may be, because we are always worried about our loss of reconstruction with time. Can you explain to me, why do you think that the angles, your angles, measurements, get better with time?
It's an excellent question. I didn't even notice it that much. I did know that the gap was increasing, and that's what my own experience is as well. And yeah, maybe the tether, like the strip of the FCR through the scaphoid, is also with like the classic Brunelli, but also with the modifications. That it's like, yeah, all the techniques address the hyperflexion of the scaphoid and like pulling it upright. But also on one of the other papers is going to address it. And I also published a paper in Journal of Wrist Surgery in 2015 that also the volar ligament can be important. And so that's why still, yeah, it can open as a book if you only address the dorsal side, and still, yeah, the gap can increase. That's why maybe also there's still radiographic deterioration and arthritis in the future. So it does loosen up maybe in this direction, but maybe the angle, I didn't, to be honest, even notice it that much. So.
Thank you.
Robert, thank you for the paper. I found the papers important in tonight's discussion because it gives us like a historical perspective. It sort of sets the ground rules. It's not the sort of technique that I think we'd probably be using these days. But basically, the patients lost about 10% of the range of motion. They got about 10% more grip strength. If you look at the whole series, 40% had osteoarthritis, 25% still had pain. These are long-term follow-ups out to 11, almost 12 years. Based on the paper, there's only one patient in 60 that had a limited wrist fusion, but I can't help but think with 40% arthritis and 25% pain that number will increase. But I think what it does is it sets up a baseline of where we can discuss the other papers of where we should be trying to take our results, whether that be with an arthroscopic or an open. And I think this really helps us with this discussion. Thank you.
Greg, can I ask your thoughts on, the natural history of neglected scapholunate complete injury is, not proven and controversial, perhaps. What are your thoughts on where these patients might end up?
So I think that's right. I don't think there is anyone who's definitively shown that. It's probably been much better understood with regard to scaphoid fractures. We know the natural history of scaphoid fractures, and we've often extrapolated that may be the same sort of thing. I think everyone on the panel would have a gut feeling that it's common for the patient to develop degenerative osteoarthritis after scapholunate injuries, and particularly when you get abnormal loading. I think Scott's pointed out the importance of the dorsal subluxation of the base of the scaphoid being associated with symptoms, and I think that's true. So although I can't say definitively the natural history, I think it's not uncommon for those patients to progress.
Absolutely. Scott, what would you like to say?
I think we've got a tremendous panel here today, and I think it would be really important if at the end of the panel we could together decide what radiographic parameters really need to be discussed in all of these papers. And I would argue that radiolunate angle and, as Greg just said, dorsal scaphoid translation are two extremely important variables that probably do lead to arthritic change and probably should be addressed along with other variables when we discuss the outcomes of these papers.
Thanks. Christoph?
Yes, Robert, it's a question for you because in 2015, I suppose, you published a paper, I think, with Mayo teams, telling us that you absolutely abandoned the bone graft technique. And in this paper, you tell us that it is the same result, whatever the technique. Could you explain?
Yeah, so what I understood from why they abandoned it was that it was technically more difficult and had similar results. I think that was the main reason.
Okay.
If it was like statistically...
Just because of the difficulty, not the result.
Yeah, I think so. Yeah. Because what we stated in our paper, maybe they had slightly more severe cases, like all complete tears and like all guys with four and so forth. But yeah, the results weren't like clearly superior. So and maybe also the capsulodesis is doing just as good as tenodesis. So maybe you could draw the same conclusion.
Thank you,
Jeff.
I found this a fabulous paper in terms of the provocative impact it had. It really points out we don't understand the natural history of the condition untreated and the natural history of the treatment of the treatments that we're doing. And the importance of treating the patient, not the x-rays. I mean, with the exception of Scott's concept of dorsal scaphoid translation, with that proximal pulse sitting on the dorsal lip of the radius, we don't really know how they're going to progress. And the most important thing is we don't make them worse. So I found it a very provocative paper and focusing on treating the patient rather than the x-rays. And the question I would raise is, that my feeling is the less destructive we are with these treatments and the better our rehab, the better our results. And my question to the author would be, what do you think about the impact of arthroscopy? Because this actually shows the evolution of thought. It goes, as we're evolving, the last one is the tenodesis, and we keep getting new techniques. Would you have any comment on the role of arthroscopy for diagnosis and minimal damage to the wrist with repairs?
Yeah, it depends on what kind of arthroscopic repair, because one of the other papers is using arthroscopy with like a tendon and a dorsal and volar reconstruction. But I think like the more severe cases with a lot of like a big SL gap and a lot of hyperflexion of the scaphoid, then my feeling is, my opinion is that it might need a stronger reconstruction. Sometimes I do a form of capsulodesis, and also with my Brunellis, my 3LTs, that sometimes I feel like also that I maybe even need to reconstruct the volar side because I don't like the idea of I use K-wires to keep the bones together for a few weeks. But then after a few months, you still see every time you see the gap increasing again. And I'd like to prevent that because, yeah, as we just discussed, like some people still develop osteoarthritis, and maybe if you do reconstruct the dorsal and the volar side, you could prevent that more.
Maria?
I'm not sure. Yeah.
I think that there are three important sentences around the article. The first one is that with the three techniques, more of the patients report a decline of pain, which is one of the reasons to keep someone to the OR. And the other sentence, which is important, is that they found that strength is improved when the range of motion is decreased and vice versa. So I really think that, as Mark told me, the instability and the stiffness are the two levels of a mountain. If you are here, you cannot be here and there. And those three techniques that they have analyzed bring the patient or here stiffness or here instability. So the end of the article where we say it says that we must continue increasing our knowledge on this topic is to try to find where the patient can be less stiff with more mobile and vice versa.
Maria, can I ask you, based on what has been said so far, the fact we're looking at lots of different techniques, some arthroscopic, some open, from your personal and your group's work on kinetic kind of biomechanical studies, which ligaments do you think we should be focusing on for complete scapholunate ligament injury?
We agree with Scott that the proximal carpal row must be as stable as possible. That it's not a problem of the scapholunate joint, but the stability of the proximal carpal row, which will bring scapholunate stability. So when we only have really scapholunate joint dysfunction, we usually only reconstruct the dorsal one because we think that the volar one is difficult to really reconstruct, and we can substitute with a volar capsulodesis if we need it. When we find that the proximal carpal row, so the lunate is unstable, then we go to reconstruct always the long radiolunate ligament.
Thank you. Thank you, Maria. Robert, you've got your hand up.
Yeah, actually, I wanted to say the same as what she just said at the end. In order to get a DC deformity, it must be that the volar ligaments are elongated or torn. And so if you operate, you get the surgical insult, you get scarring, and then maybe the lunate is already more stable. But in cases that you have still have the DC deformity, then maybe you should go to the volar side to tighten it, or maybe reconstruct the volar ligament to the scaphoid as well.
Jeff, and then I'll come to Wee.
Oh, look, the question I have is, Maria was concentrating on sentences, and I think that was a good one. One of the sentences in your paper was the surgeons should use the procedure for which they have the lowest complications, which puts a lot of responsibility on us. I know for the last 8 years, I've been measuring my outcomes at 3, 6, and 12 months, and that's a big effort. It's an expensive effort, and it takes time. So, the big thing I got out of this paper is we need to know how good we are performing ourselves and whether or not we're getting the results. Have you got any comments about how difficult that is going to be to implement in everyday practice for the hand surgeon? I agree with it completely, but it's an effort.
The question was addressed to me, sorry?
Yes, yeah? Yes. So,
yeah, okay.
I mean, you brought up, it's brilliant. I mean, what are we like? How are we going? Yeah. And I said, what I do, 3, 6, and 12-month measures, it's expensive, it's difficult, but it's the best way I've got of learning. And I think that was one of the most profound things that came out of that paper for me, because we all get lost in angles and measures, but we what do you know what that patient's like at the end of the day? What is the real problem?
Yeah, so I think nowadays also patient satisfaction and all the prompts are very important. So if a patient is very unsatisfied with how stiff the wrist was after like this many weeks of cast treatment, and also I don't experience a lot of complications myself, but you could get, of course, like a pin tract infection, or maybe some with the tenodesis, like some FCR tendinitis. But I haven't had severe complications yet. But if you do, then maybe it's better to go to a less invasive technique.
I'll come to Wee first. Wee, as editor of the journal, what are the obvious merits of this paper? Why was it chosen for publication?
Thanks, Matt, and thanks for all your hard work in organizing this journal club. So this is a retrospective study with limitations, very obvious limitations, but I think it was accepted because it is a much needed study. It is an evolving topic, a very common condition. I think we need the data. Just for authors, this is a well-designed study. It's comparing data from 3 different techniques as best as they could, from what I can see. It is not 3 papers describing 3 retrospective series, but a paper comparing all 3. And therefore, we could accept the limitations. In this case, there were many, I think, in my opinion, very wide age group, small numbers, very little pre-op data. There's no pre-op prompts that I can see. I think one of the things editors do is really to take a lot of effort to summarize the last sentence in the abstract, which was picked up by Mireia, I think, and others. And I think this abstract, I don't know whether Robert, the editor, discussed with you how to conclude what your final sentence of the abstract is. I think that sentence on the study, that this study emphasizes the need for further research is very, very important. But you know, that there might have been some discussion about how you finally want to conclude the you know, what you want the readers to know about your study. But I think overall, this paper was accepted because it was a creative use of retrospective data.
Thank you, Wee. We have one question I'd like to ask, and this will be relevant to all the papers and all the techniques. A delegate from Korea, Jung-Won Park, asks about post-operative radiographic parameters, specifically scapholunate widening. You know, for those that have done the 3-ligament tenodesis, you know, often people say never X-ray again because you will see widening. Now, it's one parameter, but what do people think with regards to, you know, the parameters we should be concentrating on? Scott?
Thanks, Matt. The big 5 are scapholunate gap, radioscaphoid angle, radiolunate angle, scapholunate angle, and dorsal scaphoid translation. I think that common to all repairs is gradual widening of the scapholunate angle, at least for complete ruptures of the scapholunate ligament, and those usually associated with additional ligament injuries. So some widening of the scapholunate gap. I think radioscaphoid angle has almost no bearing. I think whether you repair it or not, it's rarely much above 65, and it doesn't change after repair. So I think radioscaphoid angle could probably be done away with. And I think the big 2 really are radiolunate angle measured with the wrist in true lateral. In other words, no extension, radiolunate angle and dorsal scaphoid translation. Yeah.
We're going to move over to the next paper. Thank you, Scott, for that. But I just want to ask one question. Mireia, what are your thoughts on those 2 parameters, scapholunate angle and dorsal scaphoid translation?
I personally focus my practice to reduce the dorsal scapholunate translation, which I think that it's which is absolutely related to symptoms and to the slack one ongoing degeneration, which may be in the future if the proximal carpal row is not stable enough and the scaphoid is not stable enough. The impingement radioscaphoid, when the scaphoid is disconnected from the lunate, for us, is the main parameter to correct.
Fantastic, thank you. I'm sure we'll come back to these discussions, particularly with Scott's paper. I'll hand over to Bo.
Okay. So we have one full discussion. The time is running, so we move to paper number 2, which invites Christophe Marcelin to present his radiological evaluation of his technique. Please, Master. Please, Christophe.
Hello, friends. Okay, so the paper, it's okay, you see? Okay, very good. So the paper is, the purpose of the paper is that even in chronic cases and in advanced reducible stage of a WASH classification, the DZ measured by scapholunate and radiolunate angles would normalize over time without the need of additional pinning or invasive ligament reconstructive surgery, and this correction would maintain over time. So from January 2020 to January 2021, we selected the patient with scapholunate instability. We need to have a scapholunate angles more than 60 degrees and a negative radiolunate angle. We perform every time comparative bilateral Rix X-ray. That is really important in my practice, and you know that every time I ask to use the comparative dynamic X-ray, because you can have 95% of information only with the simple X-rays. So the radiolunate and scapholunate angle were measured on immediate postoperative X-ray, and then again to 3, 6, and 12 months postoperatively. We also included the patient with associated lesion of TFCC or lunotracheal ligament, and we selected the exclusion criteria: arthritis, normal preoperative SL or RL angle, of course, or intraoperative persistent scapholunate instability after the arthroscopic dorsal capsulodesis repair. Some people call that capsulodesis, but I prefer the term of repair because we restore the anatomy, requiring an additional pinning or advanced ligamentoplasty, but known in our series. So everybody knows the technique, the principle of the technique. So it's not really a capsulodesis, it's the restoration of the connection between the extrinsic ligament, which is the scaphotracheal ligament, the proximal part of the dorsal antecarpal ligament, the dorsal scapholunate ligament, and the DCSS. So we had 146 patients with 1 year follow-up. The sex ratio was 2.1 with the majority of male. The average age is almost 22 years, young people, it's logical. And the delay from injury was more than 5 months, between 0 to 11. According to the WASH classification, we have a majority of stage 4 and stage 3. It means that we are very confident in the technique and we push the limit to repair with this simple suture. 34 patients had associated reparation, etc. So the most important in this paper is the result, because we have seen that the radiolunate and scapholunate angles approach to the healthy side after 12 months. And you see the curve here. And the radiolunate angle moved from less 7 degrees to plus 4 degrees, and the scapholunate angle from 74 degrees to 54 degrees, very close to the opposite side. The most important is to see that we had 70 patients with a time from injury more than 6 months, and it is the same result. And it is the same with 69 patients with EWAS stage 4. It means a very huge lesion. Of course, it's all dynamic lesion. So we understood that, in fact, the scapholunate ligament is not the main scapholunate joint stabilizer. And in fact, there is 2 ligaments, a more important dorsal ligament and a volar one. We understood also the proprioception. And we described a long time ago the dorsal capsuloscapholunate septum, which is the bridge between the dorsal scaphotracheal ligament and the dorsal scapholunate ligament. And we chose that name with in collaboration with Mark. And we understood the very importance of the extrinsic ligament, and particularly the dorsal intrinsic ligament. And Greg published recently a very beautiful paper about this problem, and probably the dorsal is the key. So the outstanding issues is what is the real place of extrinsic ligament. Now we have to discuss not about the scapholunate ligament, but the scapholunate ligament complex. And thank you, Mark. This is the question you asked us 5 years ago. Yes, I agree with you. The extrinsic ligament are probably the first and main stabilizer of scapholunate stabilities. So in conclusion, you understand the importance of the extrinsic ligament. The arthroscopic dorsal capsulodesis repair is a very simple and reliable procedure. This study demonstrates that the repair process evolves dynamically over time, with a capsular reinforcement persisting after healing, which is effective for almost a year, facilitating the restoration of almost normal anatomy. We now have radiologic evidence that this technique seems to be sufficient to reduce the diasis over time, and seems to also normalize the scapholunate angle without need of pinning and invasive ligament reconstructive surgery. And sorry, Robert, but the place of open ligamentoplasty is reduced. Thank you very much.
Thank you, Christophe. So I believe most of us have quite familiar with Masterland's technique. So I'd like to invite the comments from our panel about this study. So Miriam, how you look at this study? Miriam.
I have the same question that I have answered before. Why do you think that the repair improves in the first year? So it not only maintains, but it improves. And I cannot
Yeah, I know. It's very complicated to understand, but it is my mantra for a long time. The healing process, in fact, is not a simple static phenomenon as we orthopedists like to believe, but it is a dynamic process that evolves over time. This has always been my mantra. We are programmed to repair this on our own. Nature is stronger than surgeon. I know it's hard to hear, but that's how it is, and we have to know that to use it.
Okay, so if you are thinking that you are going to correct the flexion, for instance, of the scaphoid, why don't you include your SLAC1 patients, as you tell in the article? Because when you are correcting the scaphoid flexion, you are improving the contact surface.
You're right. You're right. It's a good question. In fact, the principle of the technique is just to restore the anatomy. Just to restore the anatomy the best that we can. Of course, when we have a severe static cases, I have some cases like that. I put all in failure, but I never reoperated any of them until now. But it's not a good result, of course, because then after when I put some kawais at this period, when I remove the kawai, we have a gap. I understood a lot of things. The first thing, the dorsal is very important. The dorsal part is very important. And I think Greg explained us that recently in his paper. Moritomo, last year in Japan, during the Japanese meeting, informed us that if we strongly repair the volar part, we modify the movement of the scapholunate couple. Then I know now that the gap is not very important. Of course, we don't know to have an horizontalization of scaphoid, that's logical, but the gap is not important. The most important is to have a right combination of the scaphoid, between the scaphoid and the lunate. And it is very important to understand that, because even if you have a small gap, it's not a failure. It could be a failure, but it's not in all cases a failure. And if you obtain an anatomical repair of the dorsal part, it maintains a good stability over time. That is the most important, over time. And this study demonstrated that time by time, sometimes you have a reduction of the scapholunate angle better and better, because the process evolves in time. So it means we are alive. It's logical. We ameliorate by the function.
Okay, thank you.
I think one of the things that's important about this work, if we compare this paper, the previous paper went through a review of a number of open techniques. I think this is complete change where it's all done arthroscopically. So one of the advantages is some of the complications, the morbidity of the surgery is reduced. We're not devascularizing the soft tissue or de-innervating the soft tissue. So I think there are some significant advantages in going to these arthroscopic techniques as promoted by Christophe. Since Christophe's work, there's been many authors in the last 5 or 8 years that have come up with basically bigger bites and wider bites to try and address some of the more advanced types of instability. And more recently, there's been a number of examples of volar plications that will be able to address some of the volar aspect. So when I looked at the results of the paper, I thought they were generally very good. The group that actually was better than I thought they would be was the grade 4s. Certainly in my practice, I don't use this technique for a grade 4. For a grade 2 and a grade 3, it's the sort of technique that I may look at, and has certainly become much more popular in my practice, and I think in many surgeons' practice. So Christophe, my question is, with the grade 4s, the results you've published here are generally pretty good. Will you still use this technique for a grade 4, or you do other types of technique for grade 4?
So it's a good question. At the beginning, I hesitated to use this technique for the grade 4, of course, because it was huge, and every time in the beginning of my practice, a long time ago, in grade 4, I put some cow wires to stabilize the scapholunate joint and the scaphoid to capitate. And I remember once Alain Gilbert in my back look at my work on the computer and tell me, if you are confident in this technique, why do you put cow wires? So it was a good information. I removed the cow wire even in stage 4. So now I push the limit very, very far away, and I use this technique in grade 4. When we have more than grade 4, it means static cases. Sometimes I reduce the scaphoid with a big arthrolysis. It was complicated, and the result was not there. So I don't recommend this technique. But now you have seen young surgeons, my students, describe a lot of new techniques, arthroscopic techniques, to avoid the opening, and the principle is the same. So with a different device or not, depending tendon sometimes. But the principle is to have a tailored operation when you are inside the joint, and to choose if you use a simple dorsal capsulodesis repair, if you use a large one, if you use a double dynamic as described by Arnaut or Mantovani, etc., etc. You have a lot of choice of arthroscopic technique now.
Okay. Scott, you would like to say something?
Yes, thank you both. First of all, I want to congratulate Christophe and Mark Ross and Greg and others for advancing the field arthroscopically. I think this is tremendously important, and for helping us to understand what repairs we can treat arthroscopically. My question is one, really, A, clarification, B, a question. Clarification, Linscheid and Dobbins created the term DZ and said that it was 15 or more degrees increased over normal. So I think that we should be really specific in terms of which patients had DZ greater than 15 degrees and how many of them were actually corrected with any technique. Because by the time you have GAP and DZ, this is really an advanced, this is a Mark Garcia last stage 5 injury. And to correct it just with a dorsal repair and a dorsal tie down of the dorsal intercarpal ligament, at least to me, I can't understand how that would correct both gap and true DZ.
Yeah. I understand your question, but in fact, I think that the scare of the dorsal system, it means the capsule, the ligaments, the DCSS, etc. The scare evolves in time, and step by step, month by month, we have seen in this study. Step by step, month by month, you see an amelioration of scapholunate angle. I understand that it is really surprising, but it is the result of our study, and the study was performed by one of our students without any connection with us. That's like that. I think the process evolves by time, but after one year, it's over. It's finished.
Dr. Mireya?
Given that the three main complaints from patients with a scapholunate ligament deficiency are pain, limited mobility, and limited strength, which of these symptoms most strongly influences your decision to recommend your technique? Pain, lack of mobility, or lack of strength?
The principle of this technique, we open all of us, only patient with pain, of course. Because if the patient has no pain, we didn't see them. So the first thing is the pain. After that, we are orthopedists, we see the X-ray, the MRI, etc. And the second item is stability. But at the end, the most important for the patient is the mobility, of course. And it is a big surprise for us, because when I was, as everybody, at the beginning, I practiced ligamentoplasty, the Berger, mine, others, Burinelli, etc. And we obtained a good stability of scapholunate ligament. But we have a lack, in general, very frequently, a lack in flexion. And for the sportmen, high level, and in my practice, because my wife was a world champion and Olympic champion in fencing, I have a lot of fencing. If you have a lack of mobility of your wrist, it's over, it's finished, you stop. And the big surprise with this technique, that all the sportmen and sportwomen I operated with this technique retrieve their level or better. And I have a lot of patients. So the answer to your question is the third. The pain at the beginning, the stability for the X-ray because I'm orthopedist, and at the end, the most important is the function.
Okay, probably last question from Jeff.
Oh, look, Christophe, thank you. I'm an advocate of arthroscopic repair, and in the correct situations, the results are good for us. There's about a 10% reduction in palmar flexion and dorsal flexion. The big problem that they have is weight bearing and force plate, but some of these people need to understand they're not going to have a normal wrist, and the best outcome, as Mireya was talking about before, is stiffness, mobility, that interface. But my question for you is, what do you do with a patient that has a proximal pole sitting on the dorsal rim of the anterior end plate of the radius? In other words, dorsal translation, where the proximal pole is sitting right on the edge, because we know your approach to everything else, and that's clear. But what do you personally do for that small group of difficult patients?
Absolutely, you're totally right. And the arthroscopically, you can see two different things. At the beginning, I'm looking for only one thing, is how the dorsal scapholunate intrinsic ligament on the proximal pole, and in this case, it's completely avulsed. And I use an anchor, arthroscopically, I put an anchor into the proximal pole to fix this dorsal, this avulsed dorsal scapholunate ligament, and it works. But you don't have to forget that it is also another problem, is the disinsertion on the lateral scaphoid of dorsal intercarpal ligament, explaining this dorsal motion of scaphoid. So sometimes you enter for scapholunate dissociation. It could exist, but don't forget that there is also extrinsic detachment from classically from scaphoid, but sometimes from truncation too, explaining the different case you can see.
Your time is running fast, so let's move to next paper.
Thanks, Bo. So paper 3, again from the European Journal, presented by Scott Wolf from the Hospital for Special Surgery in New York. The title of the paper is Anatomical Front and Back Reconstruction Sustains Radiographic Alignment, a comparison to the three-ligament tenodesis. Scott, over to you.
Thank you, Matt. Can you see my screen? Okay.
Yeah.
Good morning from New York. On behalf of my co-authors from Hospital for Special Surgery in Manhattan, I'd like to thank the Journal of Hand Surgery European for the opportunity to present our radiographic outcomes of the novel ANAFAB repair, an exciting reconstruction for scapholunate dissociation that promises to correct some of the most difficult postural deformities of the carpus. I have no financial interest to declare. It's been 50 years since Linscheid and Dobbins defined the radiographic parameters of carpal instability and coined the terms DZ and VZ. And they identified the scaphoid as the crucial bony link of the two carpal rows. Subsequent publications demonstrated its relentless progression to instability, collapse, and incapacitating arthritis. It's estimated up to 10 million Americans alone suffer from slack arthritis. One of the most widely used scapholunate reconstruction techniques internationally is the three-ligament tenodesis. However, this reconstructive technique does not address the critical stabilizing ligaments, including the long radiolunate ligament and the dorsal intercarpal ligament. The ANAFAB reconstruction was developed by Michael Sandow to simultaneously reconstruct the dorsal scapholunate interosseous ligament as well as the critical ligament stabilizers of the proximal row. The main difference between the two techniques is that the ANAFAB also reconstructs the long radiolunate ligament and the dorsal intercarpal critical ligament stabilizers. Purpose of our study is to compare the one-year radiographic outcomes of the ANAFAB reconstruction to the three-ligament tenodesis. We hypothesized the ANAFAB would provide immediate and sustained improvements in carpal posture for patients with similar stages of scapholunate dissociation when compared to the TLT. We retrospectively identified all patients who underwent ANAFAB or TLT reconstructions for documented complete ruptures with late-stage instability, as defined by Mark Garcia Elias's classification. We compared demographic and medical comorbidities between the cohorts and excluded patients with inflammatory arthritis, failed prior repair, or slack arthritis. We included patients with at least 12 months follow-up. 5 radiographic parameters were measured preoperatively, at 16 weeks postoperatively, and at 1 year postoperatively by an independent examiner, including scapholunate gap, radioscaphoid angle, radiolunate angle, and dorsal scaphoid translation. Generalized estimating questions were used to compare radiographic parameters by time and by repair technique. The anatomical front and back technique passes a synthetic tape anchored in the trapezium through the scaphoid to augment the STT ligament complex, and then from dorsal to palmar across the lunate to reconstruct the dorsal scapholunate ligament, then across the volar carpus and through a radial tunnel to reconstruct the long radiolunate ligament. And the repair is completed by tensioning and anchoring the repair in the radial metaphysis dorsally. I should note also that an anchor is placed in the dorsal lunate hole to pull down that same dorsal intercarpal ligament complex as we just saw in the previous demonstration. Precision placement of the guide wires is critical to create a bone tunnel connecting the dorsal scapholunate insertion and the scaphoid tubercle with a 2.5 millimeter cannulated drill, followed by the lunate tunnel exiting at the long radiolunate insertion, and finally a radial tunnel through the styloid and exiting dorsally. Total of 28 patients, 16 undergoing ANAFAB and 12 undergoing TLT met the study's criteria. There were no statistically significant differences in sex, smoking status, diabetes, arthritis staging, age, height, weight, or BMI between the groups. At the 16-week postoperative time point, ANAFAB demonstrated significant improvements in all radiographic parameters, while TLT demonstrated improvements in only the scapholunate gap, radioscaphoid angle, and scapholunate angle. Of note was the lack of sustained correction of DZ or dorsal scaphoid translation at the 16-week mark of the TLT, arguably two of the most important radiographic parameters. At the 1-year postoperative time point, ANAFAB maintained significant improvements in the clinically relevant variables of scapholunate gap, radiolunate angle, and dorsal scaphoid translation, while the TLT failed to sustain improvements in any radiographic variable. The ANAFAB repair demonstrated immediate and sustained improvements in relevant radiographic parameters when compared to the widely used TLT. This may be attributable to its ability to address all three critical supporting ligaments, including the STT, the dorsal intercarpal, and the long radiolunate ligaments. This advantage makes the ANAFAB a robust option for late-stage chronic injuries with reducible carpal collapse. In closing, I'd like to thank you for your attention and give special thanks to my friend and colleague, Michael Sandow, for the genesis of this repair and literally decades of collaboration and the convergence of ideas that made this possible. Thank you.
Thanks, Scott. Great presentation and description also of the technique and your findings. Maria, I come to you first. What do you make of the paper, the technique? What are your thoughts? Any questions?
I think that the technique is very good, although it's an open technique, and you know that I love arthroscopic techniques. But I think it really redacts the proximal carpal row multiplanar misalignment found in when the wrist has a scapholunate ligament incompetence. But I have a question for Scott. In the last time, there is a good controversy about the deep fibers, the superficial fibers, the ones who go to the triquetrum. Your reconstruction really reconstructs the whole disc. Tell me something about your disc reconstruction, please.
Maria, your questions are always so on point, and thank you. So yes, one of our papers looked at the superficial and deep ligaments, and the deep ligament we call dorsal scaphoid. I mean, we don't call it. Dick Berger called it 40 years ago, the dorsal scaphoid triquetral ligament. And I think that your point is entirely correct. I think we do need to pay attention to that ligament. We do need to reconnect those deep fibers of the DIC back to their insertion point on the scaphoid, just distal and dorsal to the insertion point of the dorsal scapholunate ligament, and in some ways sometimes very densely attached to it, but I'll make a separate attachment of that now on my patients using a small anchor, a 2.0 millimeter anchor right at that insertion point, and really secure that back down again. I think that's an incredibly critical point. Thank you.
Thank you.
Greg?
Yeah, Scott, thank you very much, and to Michael Sandow as well as a collaborator, I think was the right word. So I think it's interesting. This is a radiological outcome comparing two techniques of what would have probably been your standard technique for some time. When we look at the cases that you've got there, your average preoperative scapholunate gap is 6 millimeters. So these are complex cases. This is not a simple scapholunate instability. This is a high-end scapholunate instability. And what your results don't show us as well, the times when you probably first started using this technique was when there was ulnar translocation of the carpus, because you would probably thought maybe this is the time I need to first start using this case. So I expect that your cohort, certainly in the initial phases, may have been more complex than certainly than the other discussions from any other papers tonight. The next thing is, so when you compare your results, though, of what are these complex cases versus the other ones of your TLTs, you're basically looking at the improvement. So the pre-op cases go from 6 to, I can't remember the exact number, but 4, and whereas the other one goes from 5.2 or something back. So the significant differences are more about how much you've actually improved from what was actually a bad case. But having said that, I think the cases used for the ANAFAB were actually probably more complex in your cases, and certainly in other surgeons. As soon as I speak to that start to use it, usually use it for the more complex cases. The next thing I just wanted to comment on is that Mike Sando himself presented a paper at the Mayo Clinic and raised some concerns about drill holes and different types of materials, whether it's the tendon graft or the suture material. And you may have heard Paco's work as well. So one of the questions I'd like you to address is whether you still use the technique, whether you still use the tendon graft, or whether you use a suture. And then the final thing is, I think for all of us, I think one of the big contributions here has been Mike Sando's importance of addressing the volar side, particularly the long radiolunate ligament. And so I think now we're starting to get an understanding of some of the arthroscopic options, which may cut down that complication. So a few little questions for you there, Scott.
Thank you, Greg. This is like a psychological test. Do I remember 3 complex things at once? So anyway, first is that yes, this is predominantly used in the late stage deformities, as I tried to make clear. So certainly wide open scapholunate gaps, but those with DZ and dorsal scaphoid translation. I began by actually using it on SLAC patients, both 1 and 2, and found out fairly quickly that the 2 is very difficult to correct. I think you hit the nail on the head saying that ulnar translation can occur. Long radiolunate reconstruction will not in and of itself correct ulnar translation. I think that the short radiolunate ligament has been overplayed in that regard. I actually think the dorsal radiocarpal ligament is probably extremely important in preventing that dorsal ulnar the ulnar translation. And if we don't have ways to correct that, which the NFAB does not, we may be missing on those patients. So I think caution is warranted there. Yes, second question, yes, I still use the technique. I do hear and read all of the papers on problems of osteolysis, on tunnel widening, on tapes. One of the nice things about this repair is it's generated lots of other studies. So we're currently doing a lot of basic science understanding of all of the different synthetics that we could potentially use, and we hope to have that data available soon. Some of them break very quickly, some of them wear with time, some of them splinter. Does in these polyethylene laced sutures, like, well, I don't want to mention any proprietary names, but some of them have polyethylene. Is that polyethylene released into the milieu, and does that create osteolysis? These are all really important questions, really hard to study. One thing I think that we don't do is we don't put those giant anchors inside the scaphoid or the lunate. We keep those really big peak anchors out of the scaphoid and the lunate. I think that's very important. And there, I didn't remember your specifics of your last question, but if I haven't covered anything, I'd be happy to try.
Yeah.
Thanks. Maria, you've got your hand up.
So, Scott, please, for our audience, we have previously said that the main issue for a patient's pain is dorsal scaphoid translation. So, do you think that the only way to efficiently control this dorsal scaphoid translation is to pull from the volar, because the techniques which only go dorsally are not able to efficiently control that? Or do you really think that some of the only dorsal repairs are able to control this bad radiological sign which interferes in the future of the patient?
There you go again, Morella, asking questions that can't be answered. Thank you for that. It's another really critical question. And so Len Ruby, to my knowledge, is the only one that even spoke about dorsal translation back in the 80s, and he found it in 2 patients in a cutting experiment on 4. He found it after he divided the dorsal radiocarpal ligament, which is very interesting. He had also divided the scapholunate and several other ligaments to produce it. But so that's very interesting. I think you're 100% right. Unless we correct the scaphotriquetral trapezoid complex, and I say complex because that also includes the scaphocapitate ligament, which is a forgotten ligament in many people's eyes. But addressing that whole complex helps to bring the scaphoid back into the right rotational alignment. but you've got to do something dorsally to hold it down, whether that's dorsal radiocarpal ligament or just a really firm repair of the dorsal scaphoid triquetral and dorsal scaphoid, the scaphoid insertion of the dorsal intercarpal ligament. Can't be said right now. However, in our other paper looking at our 1-year outcomes, we did correct dorsal scaphoid translation with this repair. We also showed improvements in pain with the PRWE, statistical improvements in pain, and with the promised pain and function scores.
Thank you, Scott. We've actually got Michael Sandar as one of our attendees. I wondered if he had any comments on his technique.
Well, this is a great forum. Can you hear me?
Yeah.
Can you hear me? Yeah.
Yes.
No, this is a great forum, and I think that I was very pleased that Scott basically has taken on this technique, because I think we're over discussions over many years, we're a little unhappy with some of the techniques, and I think our work on the volar and dorsal constraints has sort of led us to the ANAFAB over the last probably 2 decades. And when we published the ANAFAB maybe nearly 5 years ago, it seemed to address some of the issues we had, but certainly the bone tunnels have always been a big issue and a big concern. And certainly Scott and I have discussed this at great depth. And I think the concern about polyethylene sutures, which are really the more common now stabilizing sutures, is a real concern. And certainly Bill Walsh in Sydney has shown some really nasty reactions to wear particles with metalloproteinase upregulation and bone tunnel enlargement. And I guess one of the good things about doing these challenging cases is you do have a few failures, and you can certainly learn from your failures. And I guess a couple that I've had where I had a fracture into a lunate tunnel, which basically meant he needed a medial column fusion, which basically allowed me to then harvest the scaphoid, which is a bit tragic for the patient, but very, very handy to find out what happened. And what was curious is that the bone tunnel to the scaphoid was completely corticalized with no tendon and just fragments of suture there. And it really hadn't incorporated at all the suture or the tendon, should we say. So these are sort of things that I'm concerned about the tunnels. And I think certainly I agree with Christoph saying that many of these great techniques have reduced the need for these open tenodesis. But I absolutely agree with that. And certainly I reserve the ANAFAB for really stage 5 and 6, really almost exclusively, maybe bad stage 4. So it's certainly been a works in progress. We've had a few concerns. I think we're moving now to braided polyester tapes. I think that may be an answer. Sorry, polyester tapes. And I think that may be the answer. And I've gone away from tendon strips for probably nearly a couple of years now. So no, it's works in progress, but it seems to have filled that niche for those really nasty, unstable, stable collapses. And I guess I'd also mention that the displacement of the scapholunate is actually in 3D, where the scaphoid goes dorsally, it pronates, and really goes way away from the lunate. So it's not just a uniplanar separation. So I'm not sure how much the post-op 2D gap actually means compared to the very significant pre-op 3D displacement. Thanks. Appreciate the comment, the chance to make a comment.
Thank you for joining. Scott, can I just follow up? Obviously your paper focused on radiographic parameters. You mentioned PROMs. In terms of pain and function, how do you compare the two techniques?
We use the PRWE, which have pain and functional subscales, and both of them were in our other paper at 1 year, which was really 18 months follow-up, 21 months follow-up. Both were improved. And Greg, yes, I do still use tenographs.
Robert, you've got your hand up.
Yeah, I had a similar question as you just asked, but first I want to say I think it's a beautiful technique, and especially doing so arthroscopically. This paper is about the radiographic parameters, but you already asked a question about pain. He also treats patients with SLAC1. I guess with this technique, because he's doing it arthroscopically, he's not doing anything to the PIN. And maybe also, does he treat the radial styloid in the SLAC cases? And how are they doing? Like you said, they are doing PRWE and DAS questionnaires. But in case of range of motion, how are they doing?
Thank you, Robert. First of all, I don't actually do this arthroscopically. I think you probably could, but it might take you longer. But your point is well taken, and I make these tiny little window approaches. So mini open would be the correct definition of how we assault the capsule. Just a very small non-ligamentous opening in the capsular portion without damaging or touching the ligaments. Secondly, your last point was the one I wanted to address. What was that?
The last one, I guess the range of motion and the pain with the radial styloid.
Yeah, so styloid rarely, if it's really beaked or large, or there's a big osteophyte, I'll take that off for sure. If it's just got a little cartilage loss on the end, I don't take it out because we're correcting the scaphoid. And we do lose range of motion. The only parameter where that was statistically significant was loss of flexion. I think that's because our patients started in 15 or more degrees of dorsal tilt, and they've already exhausted the amount of lunate correction they can get. To Michael's point just a minute ago, I don't do this in fixed deformities, the so-called marker CLI 6, because in patients who have a perched and stuck scaphoid on the dorsal rim, you're not going to make that better. In patients that don't correct their lunate with some degree of wrist flexion, they're not going to do better either. So I would withhold this technique for someone in a true stage 6 myself.
Thank you, Scott. We'll go to Jeff in one moment, and then we'll go on to the next paper. Just for our delegates, I just want to say that once we've gone through all 4 papers, we've got one more paper. We'll then spend about 10 minutes summarizing, okay, to see where we stand with different maybe case examples. So, Jeff, what would you like to add?
Oh, Scott, you answered the question partially when you said when the scaphoid proximal pole was perched on the dorsal lip of the radius, that was a preclusion for the anafab for you. Was that accurate?
That is. In patients that have reducible scaphoid, so in that same flexion extension lateral, when we extend our wrist, we should, on a lateral radiograph, we should see the scaphoid reduce perfectly back into its fossa. We should see the lunate extend even further. When we get the flexion lateral, the opposite should occur. The scaphoid should sublux out of its fossa, and the lunate should at least come to neutral, if not a few degrees beyond, if that's going to be a good candidate for repair.
Because the real question there is a little bit of dorsal subluxation may well respond to an arthroscopic ligament tightening, whereas the more severe ones are going to need an anafab. And do you have a classification for your dorsal translocation of the scaphoid? And are you using 4D CTs to get a better idea about how the scaphoid is rocking and moving relative to the proximal pole and the midcarpal joint?
An incredibly good question. First of all, dorsal scaphoid translation is the most difficult of the radiographic parameters to measure, and it takes exceedingly precise radiographs to do that. So to come up with, I mean, when we're talking about something that may be measured in terms of 1 millimeter or 2 millimeters, we're talking about a very fine distinction between severe and none. I would say the severe ones are the ones when you get an x-ray, the scaphoid is sitting on the radius when you get a true lateral x-ray, and the less severe are those that clearly clunk out with a scaphoid shift maneuver, et cetera, and clunk out dynamically with that flexion lateral. That's the only way I could differentiate them.
I think that there is a dynamic maneuver which is important to suspect a dorsal translation of the radius, which is trying to extend your wrist while you are pushing over the second and the third metacarpal in this way. When the scaphoid tends to impinge on the dorsal radius, this is painful. And it's a clinical exam.
Thank you all. I'll hand over to Bo. Thanks, Bo.
Okay, thanks. So our next paper and our last paper will be presented by Mark Ross, who's talking about clinical outcomes of arthroscopic ligament-sparing dorsal capsulodesis for partial scapholunate ligament tear. Please, Mark.
Thanks very much. This is a paper from Journal of Wrist Surgery in 2022, and I'd like to thank co-authors, particularly Greg Cousins, one of my partners in crime over many years, as well as Ben Hope and our fellows, Matt Curran from Canada and Stephanie Waschleck from Germany, who did a lot of the follow-up work. So no disclosures relevant to this topic, although I should disclose that I'm a reformed holer. We've published on drilling holes in carpal bones a lot in the past, but I've almost completely given up and now do almost all of my reconstructions arthroscopically without bone tunnels. This is the cohort of patients. We had 23 patients with an average age of 41, and most of them were grade 2 injuries, 20, and 3 of them were grade 3 injuries. And there's a long interval from injury to surgery. You can see their average of 18 months. And all of these patients were given a trial of neuromuscular rehabilitation and had all failed rehabilitation. The technique was thermal capsular shrinkage, but what we were particularly interested in doing was shrinking the area between the key ligaments and avoiding shrinkage of the posterior interosseous nerve or the key ligaments or the scapholunate ligament itself. So we basically shrunk this area, the goal being to tighten the dorsal capsule and to improve scaphoid extension. These are our results. You can see reasonable improvements in VAS pain scores at 24 months and high improvements in satisfaction. You can see the median satisfaction there was extremely low and then improved to almost 90 at 24 months. In terms of objective outcomes, the only thing that really changed was improvement in extension range. The grip strength improved a small amount, and all the other ranges stayed the same. So these were reasonable. In terms of radiographic outcomes, we certainly didn't get deterioration, obviously, because most of these were dynamic instabilities or partial injuries. There was a trend towards some improvements in the radiographic parameters, but certainly the important thing was there were no deteriorations in radiographic parameters and no development of any chondrolysis in the joints. In terms of salvage, there were some patients who had persisting symptoms, and the important thing to note there was that the 2 of the 3 grade 3 injuries required a salvage procedure. So to conclude, I think the important thing is that this cohort of patients was in between 2010 and 2015 when we were in developing some of the arthroscopic techniques that we use. And it's probably important to note that at that time we weren't examining these patients carefully for dissociation of the dorsal capsular ligaments from the proximal row. So particularly the so-called bare area on the lunate that we described is something that we had not been identifying in these patients, either dissociation from the lunate of the DRC and DIC or dissociation of the DIC from the scaphoid. And when we went back and looked at these patients, this is after the publication, we noted that there was a correlation. We have all of the MRIs of these patients to review, and we noted that they did have capsular dissociations, and there was a correlation between the patients who had capsular dissociations off the proximal row and poorer outcomes. So I think in most cases, we now prefer an anchor capsulodesis plus or minus a combination with a wide ADCLR for these grade 2 and grade 3 injuries. And we still use this technique occasionally, but only in patients who have a partial scapholunate injury and no capsular dissociation from the proximal row. So that's a summary.
Thank you, Mark. So I'd like to, Maria, I would like to ask you your opinion about this.
So I have enjoyed this article. Why? Because it talks about ligaments, proprioception, mechanoreceptors, and we haven't talked about that all our session, but I think that this is very important. And thank you, Mark, for sparing your ligament mechanoreceptors with your technique. So could you explain to the audience, you make a thermic reefing of the same window capsulography that have explained Scott, and which is the real difference between your capsulography and Matu capsulodesis? And do you also see an evolution to improve the angles with the time, please?
So we didn't have in this cohort of patients a lot of poor radiographic angles to begin with. So we saw some trends towards some mild improvements or changes, but nothing that was statistically significant. The difference to Christoph's technique is that in Christoph's technique, the plication is from medial to lateral and is reassociating the dorsal capsule with the proximal row, and I think that's important, which is one of the reasons why we've also migrated to that type of technique. What this technique does is it decreases scaphoid flexion and tightens the DIC and DRC by pulling them closer together in that angle.
Thank you.
Okay. Okay, Greg?
So thanks, Mark. I think it's pretty clear you've shown that in the category 2s or grade 2s, they generally do pretty well. The grade 3s, they're not doing so well. And as you say, the radio frequency is probably a lot less popular, but as you suggested as well, it's 2010 to 2015. So that's a long time ago that you were doing this. I expect that most people wouldn't be going to the radio frequency and they're going to the capsulodesis, as you suggested. And Christoph's technique is a little bit more distal than where you are. So I think you've summarized it, actually. So one question. You described in 4 cases you did a capsular abrasion. Do you think there's any role for that still?
I mean, the intent is to create a healing response in that area of the capsule. But now we would just use a suture arthroscopically to placate it rather than doing that. But you know, we were still developing, like most people, we were developing suture techniques after that.
The nice thing about this is it's very simple. It's very simple to do, isn't it?
It is. If you don't have the instruments or the technical familiarity to perform suture capsulodesis, it is a simple technique.
Yeah.
Mark, thank you for clarifying what cases you'll use this in now, and it sounds like you won't use it for complete divisions of the scapholunate ligament anymore, because I think one of the other overarching themes that I hope we can all agree to is that we need to use different repairs for different scapholunate ligament problems, and so that's a very important clarification. My question to you is, if this capsular shrinkage is powerful enough to decrease scaphoid flexion, why is it that it doesn't decrease wrist motion, to Mireille's question earlier? Should it not, on that slope, should it, if you are really decreasing instability, should it not decrease motion also?
I guess it depends on what you think it's actually doing. I think that it's tightening, indirectly tightening the DRC and the DIC by shrinking that tissue in the triangle between them. And so perhaps it doesn't impact on the motion of those ligaments. I mean, in response to your other comment, I completely agree that we now need a modular or ligament-specific approach where you have the capacity to arthroscopically deal with all of the impacted ligaments. And in fact, we think now that we can arthroscopically do everything that the ANAFAB does, including the long radiolunate plication, which we've recently perfected arthroscopically.
Mirella, you would like to say something?
Yes. When Matu has showed us his capsulodesis, in his article, he says that he maintains the extension of the wrist for 6 weeks. Do you also do that in a pushed extension position, or what do you prefer?
Whether we do this when we're doing the shrinkage or capsular or suture capsulodesis, we place the thermoplastic splint and we allow the patients to flex only to 10 degrees and extend to 30 degrees. So we have very limited movement. I mean, that seems to work for us. And we prefer a little bit of flexion, and it doesn't seem to stress the repairs.
So Matt, seems we have a wonderful timing now. So if we don't have more questions, probably we can go to our final discussions.
Yeah, great. Thank you all for the papers and for your contributions. It's been fascinating. We'll try and bring things together. I'll throw in a few cases and we'll get shows of hands and things. But first, I wouldn't mind going to Jeff first and then others. You know, when you're seeing a patient in clinic that you think might have a scapholunate ligament injury, what is your classic workup beyond, for example, examination?
It is the same every time, because if you examine the wrist the same every time, then you'll get an idea about what's normal and abnormal, and you must always compare the other wrist not to get caught out. The first thing is, where is your pain? Point to it, because frequently scapholunate injuries are part of a global injury to the wrist, and often there is TFCC injuries, and you don't want to miss it. And as Mark Garciales pointed out, occasionally, rarely, you'll get an ECU and you don't want to miss that. So clinically finding out where their pain is, and then a clinical examination of the entire wrist, radiocarpal, midcarpal joint, DRUJ, and if there's any doubt about the ECU, I'll run an ultrasound on it. The next thing is standard imaging, and I use functional X-rays, radial ulnar deviation, palmar flexion, dorsal flexion, clenched fist, and variance views, always look at the variance, okay? CT scan, MRI scan, and often these things are just filling in holes, and I have the luxury of being able to get those tests. The other thing I'll do is dynamometer test. I'll check their grip strength, and in particular, pronation, supination, and weight bearing, force plate measurements. They're very, very important to me. And that is just the start, because I do not believe there is a test that'll give you scapholunate instability clinically. The next one is arthroscopy, and I don't know anything that has changed my perception more than arthroscopy. And the arthroscopy should be the same as a wrist examination. When you examine a wrist, you should be able to get through it in 90 seconds with everything. The same is with arthroscopy, midcarpal joint, radiocarpal joint, arthroscopy, and looking at everything, the CR portal, using the pisiform triquetral joint, looking at the recesses, the TFCC, everything, but also dry arthroscopy of the DRUJ. And I do that all the time, and I admit a lot of people don't do that. We're published on it. It takes 5 to 6 minutes, but you get all the information and you really know what you're dealing with, and you've got the whole picture. Then I repair them, and I repair them with informed consent beforehand. It was something straightforward like a wide arthroscopic scape or triquetral capsulodesis, which we've been doing for 8 years. I very, very rarely use tendon grafts. I stopped using tendon grafts 8 years ago because they're too damaging and the results aren't good enough. I'll repair it. If there's a TFCC tear, I'll repair it. Very, very rarely, 3 to 5%, you can't repair the TFCC and needs a tendon graft. So that's what I do with all of them. They go straight to therapy the next day. They have a splint. They start movement, controlled movement, because immobilization and KYs damages wrists. They come out of their splint at 6 weeks. Their power returns usually at 4 months, and we measure their power at 3, 6, and 12 months. And with that approach, excluding Scott's ugly dorsal translation of the scaphoid, which is rare, perched on it, our results have been very good. And the one question that I basically 10% down palmar flexion, dorsal flexion, and almost written out. I don't do partial wrist fusions arthroscopically anymore, very, very rarely, nor do I have any of the other complications. So I found it a very good way of looking at it. Obviously, there's patient selection. You pick the wrong patient, you're not going to get the right answer. And my big question, my really big question is, in the cases that Mark Ross was talking about, what happens if we leave them alone and give them proprioceptive exercises? What happens if we allow the brain, its neuroplasticity, to adapt, as Matulin and Ray were talking about, to balance the wrist with time? And I think it's really, really important that we measure our own results. We know what we're getting, we stay out of trouble, and we don't hurt people. Sorry, it's a bit of a dialogue, but that's every time the same.
Thanks, Jeff. Greg, maybe Maria afterwards. We've got a question from Pieter Jordan in South Africa asking about an algorithm. We know that Garcia Elias has his questions. How do you decide what the patient's going to have, whether it's surgery or not surgery, or the type of surgery?
Ligament complexes are violated, and I would be addressing those individually depending upon exactly what I find. And I'd use arthroscopy, intraoperatively doing stress tests to try and understand whether I can unmask any of those types of instability.
Thanks. Maria, any further thoughts?
Your question was, what do I do, or how
Yeah.
do I plan?
Yeah.
So I do ask Jeff the same systematic exploration with loading, with mobility, with everything. I have an ultrasound device in my consultation, and I try to dynamically see how the dorsal scaphoid dorsally migrates. And then I do the bats that we published in the journal 2 or 3 years ago, which is an active provocation of the gap between the scapholunate and the lunate. If it's not a major instability, so the scaphoid does not come and down clearly, I send my patients to the hand therapy to strengthen the stabilizer muscles. And I see them again at 2-3 months. If they go better, they continue. If they do not go better, they go into the OR. And if it's a major, we go directly to the OR. And what I do, I perform a Corellia technique, which is an arthroscopic dorsal and volar reconstruction, volar capsulodesis, dorsal tenodesis. But first, when I have my patient under the anesthesia, I check the competence of the long radiolunate. And I try to translate my carpus from the radius to see if there is an incompetence there. Because if there is, I go for a spiral technique reconstruction.
Thank you. Thanks, Maria. What are your thoughts on the where should we be focusing future research efforts, basically?
Thanks, Matt. Fascinating area of hand surgery. There are a few very sort of controversial topics. This is one of them. We invited Greg to write an article on this. Greg, if you remember, in the special issue on unsolved problems on hand surgery last year. I think in the future, in terms of publication, there are many classical techniques. There are some relatively new techniques. I think the strength lies in comparative cohort studies, not just single retrospective studies. Scott's NFAP series was a great series in itself, but I think the comparison took it to another level. And so to future authors, if you submit comparative cohort studies, I think that will increase your chances of acceptance, because this is very important data. And I think in the future, I don't know, I mean, prospective studies, I don't know whether they are possible, comparing different techniques, but it's important to think about using the same level of severity, same outcome measures, same radiological parameters, same way of classification, or maybe compare it with doing nothing. Maybe that's the way to forward.
Thanks, So if I come back, so Scott, you got your hand up, and at the beginning you talked about, can we standardize or decide what radiographic parameters we should be all using if we're publishing? Summarize your thoughts.
Yeah, so I just want to really echo what we just said, and that is, because any given orthopedic, plastic, hand surgeon sees only a few of these every year in your general population. I mean, the specialists on this call are different, but they see 2, 3, 4, maybe none in a year. We see more because we're referral centers. But what we really need to do is, as we just said, is prospective studies amongst the people who are doing reasonable numbers of these, following those all with the same classification system, whether it's EWAS if you're arthroscopic, or Mark Garcia Elias, or another classification for those who do it open. Let's agree on it. Let's follow them. Let's classify them. And then let's follow them forward with the same patient outcome studies, with the same radiographic parameters. Those I said were at scapholunate gap, radioscaphoid angle, radiolunate angle, scapholunate angle, and dorsal scaphoid translation. I think that's the big 5. I think some of them will shake out as being more important than others, but I think we do have to measure them, and there are techniques to do all that. So large multi-center studies looking at large numbers of all these repairs and then following them for 6 months, 1 year, 2 years, 5 years, and 10 years are what's going to answer the question of the type of repair for the type of injury, but also how do we stop arthritic progression?
Thanks, Scott. Okay, so I'll go to Mark, then Jeff, and then I'm going to give you all a clinical scenario. So, Mark.
Just a quick comment on subjective scores. We've got a paper we're about to publish looking at the sensitivity of PRWE and DASH to carpal instability, and they're not very sensitive. So one of the problems using those scores is they're not sensitive enough to pick up improvements in patient function from any given treatment that the patient considers significant. So we use an anchor study. We use GRC symptoms and GRC, global rating of change of function, and we found that PRWE and quick dash are not that great for determining which treatments help. So I just urge people to think about what they're using to make decisions about outcomes.
Thanks. Jeff?
Well, look, 2 comments. I agree, we really need information, but we need to include controls, people that aren't treated, and we need to look at our proprioceptive rehabilitation programs. There seems to be a paucity in this webinar. And to me, one of the most important things is neuroplasticity, your therapist and the patient compliance working on exercises. Because we have to prove that we're better than the natural history, and we have to prove that our risk-benefit ratio is worth it. And new heroic ideas without data are very sad.
Maria, your hand is up, and would you like to talk about your, how should we pre-rehabilitate or post-operative rehabilitate?
Sorry. Only a little thing that I think that if we are planning and deciding that the main important thing is to standardize and the evolution and the techniques, we also take into account that those are difficult techniques and the learning curves are important, and that although we have seen many techniques now, we as responsible surgeons, we should choose 1, maximal 2 techniques to master them, because in this way we can bring as much as possible good result to our patients, which are with a kinetic and a kinematic wrist problem, which is not easy to solve. And this is, I think it's a good message for everyone. And what was the question, please?
So let's go post-op rehab. What's for your Correa technique? What do you focus on, muscle or motor-wise?
I show them the muscle strengthening before, because they go first to the hand therapist, or I show to them because I sometimes do not have hand therapist. And then just 2 weeks after, when they are still wearing their cast or orthosis, they are keeping strengthening their stabilizing muscles, and they start moving at 2 weeks post-op. And we have published in the Spanish Society journal 2 or 3 months ago our protocol, which is very well designed to keep the biology of the repair and to avoid muscle atrophy, and to keep the proprioceptive and neuromuscular control going through all the recovery time.
Nearly finished. I'm going to present 2 types of patient, and I want a show of hands, and someone can talk about their option chosen if they want. A show of hands on whether you would offer them an operation, whether it's arthroscopic or open, something for a complete scapholunate injury that's been diagnosed through any way. So let's say you've got a male or female, 30, moderate active job, who has no arthritis, has minimal X-ray changes, but proven, with dynamism, that there's a complete SL injury. And their symptom profile is relatively mild, maybe moderate at times, but activity related. They can do most things. Difficult patient. what are you recommending for them other than, physiotherapy? Would you recommend surgery, for example, to prevent arthritic deterioration? Who would recommend surgery at some point? And if you're not sure, tell us why. Okay, we've got a few hands up. Maria?
I think one of the things is the duration of symptoms. So if it's like within, say, less than 3 months, immobilization of the wrist, I think, will do very well in that patient.
Yeah, Maria?
I personally never indicate some surgery to prevent what I do not know if it will come, which is an arthritis degeneration, because any surgery has a possibility of complications which can be worse than the possibility in 10 years to have an arthritic wrist.
Yeah. Scott?
You need to know a little bit more information. Maybe I missed it, but is this acute or chronic? If it's less than 6 weeks, it might not show radiographic abnormalities, and it may truly be a complete disruption, and there may be other ligaments involved. So at the risk of what others on this panel may consider as heresy, I really put a lot of credence in our MRIs. We have a tremendous ability to use high-resolution MRIs with less than a millimeter between slices, overlapping slices, etc. We can characterize cartilage, we can characterize ligaments, we can see beautifully without arthroscopy. I certainly support everyone who uses arthroscopy, but I can do it with that. So I would do a high-resolution MRI, see what other ligaments are injured, and if it's acute, probably operate.
Yeah. Jeff?
I think there's a lot of information missing. I would never operate to prevent arthritis. I don't think the data is there. I agree with Ray. I think what we often underappreciate is the ability of patients to adapt and their resilience. And they'll often wander in and say, I have minimal symptoms. But when you really push their exam, you'll find they're operating in a very narrow tunnel of their comfort. The other thing that I found is that people that come in at 3 months with wrist pain can often have an MRI scan, and I don't have Scott's ability to read these things as accurate as what Scott can. There's often not much to see, and when you put a scope in, they've got a wide drive inside the scapholunate is opening right up, and in those cases that have failed their treatment, arthroscopy becomes a very important tool and part of the diagnostic process, but not by itself, because you can have asymptomatic findings on scope. It has to be the whole thing. The symptoms, the clinical findings, or your measurements, your dynamometer. And when you've got symptomatic people like that, and you are skilled at arthroscopy, you really need to have done a lot of arthroscopy. Otherwise, you make up stories in your head or you make a mess. You have to know what's normal. And if all that fits together, then I'll repair them. I'll do a wide arthroscopy, dorsal scaphotracheal ligament repair with good rehab. But you really need a lot of information, and you need to get it all together. And what I've found is if you've got really good clinical signs, you've got perilunate tenderness, you've got pain, you've got a DAUJ there, 90% of the time you're going to find something significantly you can fix. If you don't have good clinical signs and it doesn't add up, you're wasting your time and you're damaging people.
Thanks, Jeff. I'll come to Robert. We're nearly there. Jeff, if you had that patient that you were going to operate on, but they actually had, grade 1 slack, how would that change your journey to surgery?
Oh God, that is a really great question. There's areas where they're grey and they're really, really awkward, and I don't have the answer for that. I'm not operating on slack arthritis with this technique. That's why I get good results. I select them out. I don't have an answer, but I am starting to think that there may be a role for it, but I don't have the answer for that, and that's difficult. You have to talk to the patient. You have to come to terms with yourself. You have to come to terms with the arguments within yourself about whether you're going to make them better or worse. I'll leave that for the rest of the panel. That one hurts. Good question.
Yeah. Robert?
Yeah, so if the patient comes to me, they apparently have complaints, so they usually have pain. And if the pain is persistent, it doesn't go away by time, then I would definitely discuss an operation with them. And I also tell them that the natural course is unknown, so they might not develop arthritis, but I think many will do. So then it's also for the patient to decide, because it will result, I usually offer them the 3LT, that it will result in loss of wrist motion. And also if they don't want to, if it's just a pain they want to have treated and want to take the risk of getting arthritis, I had a patient this week as well, then they chose the wrist denervation, so they have like less pain for at least a few years.
If anyone's got anything burning to say at this point, please raise your hands. No. Maria, it's not Maria, sorry. Oh, your hand is up. Okay, Maria.
Hand is up.
You changed on my screen. Yeah.
You asked if I would reconstruct even if there was a slag one. Is that okay?
Yes.
I would. Why? Because when I reconstruct, I am changing the scaphoid position. So I am decompressing the degenerative cartilage surface, and I am pushing my scaphoid over. My radioscaphoid joint is in a new normal cartilage surface first. And second, has Robert told to denervate the joint? Is that okay? I have understood that okay.
Yeah, I quite often tell them that as an option as well for a total wrist denervation.
In a young patient with scapholunate instability, laxity, static, dynamic?
Well, maybe not for the youngest patient, but if they're like the manual laborers and they have a lot of pain from their SL injury, then and they don't want to lose like too much flexion, or then to be able to get back to work again, it is an option to me.
And they have already arthritic changes. So you are treating the pain of the arthritic changes, or you are treating the wrist dysfunction, cinematic or kinetic?
No, this is just for the pain treatment.
Pain treatment of the arthritic. Okay, thank you.
Yeah.
That's great. Thanks, everyone. We could continue talking for a very long time. Unless anyone's got something burning to say, I'd just like to say thank you to everyone who's contributed to this panel and put in a lot of effort over the last few weeks, if not months. All our participants from all over the world, it's really encouraging. I'm sure there'll be room for a part 2 for this. And I'd like to ask Jeff for his concluding thoughts on the webinar and scapholunate injuries in general.
Oh, well, thank you. I wasn't planning to conclude the session. I thought somebody else did because I opened it. But what I'd say, this has been a very good webinar because it's opened our eyes. It's provocative. We've had some incredible experts speaking. We've had diverse opinions. We understand that we need to learn. We understand we need to be honest. And it's incredibly important that we continue this train of thinking. And I thank Bo for starting this, and Matt for your immense organization, Murray and Greg for really going through this properly. And I just wish I knew what was going on with all those people online with enormous amounts of experience. And I congratulate for you on this. And I would like to say that APWA, Asia Pacific Wrist Association, is a very, very dynamic group. And I think with Bo's efforts here, we're uniting the European group with the American group, and we're joining the world. And thank you, Bo, because one of the most dynamic areas that I know is the Asia Pacific axis, because they've got big populations, big numbers, big turnovers. They're incredibly innovative, and stuff is really happening, and we all need to work together. So thank you to everyone.
That's great. Thanks, Jeff. Thanks, Bo. Thanks, Rebecca, for timekeeping. Thanks, Mark, Maria, Scott, Robert, and Greg. I'll say goodbye and good luck with everyone treating this fascinating patient cohort.